Thank you for joining me today. In this video, I have a case study, treatment persistent depression. So I have this case study. This case study, you meet this patient. This patient is 47 years old. And you met them during outpatient follow-up. That was referred to you after they were referred back to the psychiatric for a persistent depression symptoms despite the adequate antidepressant treatment. So they've been referred to you and they have persistent depression. They arrive on time. Medication bottles are nearly organized and clearly invested in their care. So they invested on their care. That means they want to feel better. They want to take their medication. They come the follow up on time. And their psychiatric history include recurrent major depression disorder diagnosis over a decade, with no history of manic or hypomania or psychosis or suicide. So they don't have the other comorbidity. Only thing they have is that resistant depression disorder. And over the last 3 years, they complete 2 full antidepressant medication trials. Zoloft, they had a Zoloft 150 milligram daily, and also they had escitalopram 20 milligram daily, each taken consistently for more than 12 weeks. So this patient clearly they take their medication, they follow up their appointments, they want to feel better. They had these 2 different medication, and they also, because depression medication takes time, it have been already 12 weeks and it's not controlling the symptoms. They describe meaningful improvement in sadness, emotion reactivity, but continue to struggle with the fatigue, diminished motivation, anhedonia, and cognitive slowing. So some of the symptoms improved, but not everything improved. So they still have some of the symptoms, but some of the symptoms have been improved. These symptoms interfere with work, performance, and relationships. Today, BHQ9 score is 14. that indicate persistent migraine depression. So their score shows that they still have the migraine depression. You review their medical history. Hypertension well controlled. They have hypertension well controlled, no endocrine disease. They don't have no endocrine disease, but they have hypertension that is well controlled. Current medication is a laboratory workup. So you did the CBC and CMP and TSH, vitamin B12, and vitamin D. They are all within normal limits. So there is no issue on that. There are no red flags suggesting bipolar disorder or medical contribution to the mood symptoms. So their lab and medical history come normal. There is no other indication that tells you there is a other comorbidity causing the persistent depression. So you continue assessment and diagnosis reasoning. You determine this is a treatment resistant depression with partial SSRI response. So patient has some responded to the medication, but not all of it. Not antidepressant failure. You explain to the patient that the SSRIs primarily address the serotonin symptoms such as sadness, anxiety, while residue symptoms like a fatigue, low motivation, low cognitive, often reflected dopaminic and neurotransmitter defects. So you explain that to the patient, you educate the patient. Then the primary treatment plan, you recommended other medication rather than switching the two medications that the patient have. So you add third medication, bupropion, extended release, 150 milligram daily, while continuing the SSRIs. And you explain to them that the bupropion targets dopamine and norepinephrine, which may improve the energy, motivation, and concentration. So also you have additional and alternative treatment options. Some of these treatment options will be aripiprazole, brexpiprazole. You can add this to the two SSRIs that the patient was taking. You can add this, or you can add lithium adjacent. Partial if the patient have a suicidal ideation. Emergency, you can add lithium. You can also switch the SSRIs to SNRIs like venlafaxine or duloxetine. You can also add to the treatment TMS or escitalopram referral for persistent treatment TRDs. Then you also have other options, psychotherapy and non-pharmacological care. Then you recommend the patient cognitive behavior therapy and interference behavior activation. Encouraging structure to encourage structure, achievability, activity, goals, and to counter avoidance. And then you provided patient education. You explain that needing more than one. You explain to the patient that they need more than one medication, which does not mean failure. You reviewed their potential side effects of the medication, like activation, insomnia, blood pressure elevation. You emphasize the importance of monitoring and follow-up. And then you schedule follow-up and referral. You should schedule the follow-up within 4 to 6 weeks to repeat the PHQ-9 and discuss escalation of the care if the remission is not achieved.